Good morning to everybody. Welcome to this very interesting session about two implementation in two different countries about the COVID-19 approach. We have the first presentation that is from Italy and the second one that is from Netherlands. And the first presentation, I will introduce Beatrice del Frate, that is the healthcare CIO of Friuli Venezia Giulia region. And she is in charge of all the part of coordination and strategy approach in the COVID-19 from the technical point of view. Then Maurizio Rizzetto, that is the CIO of the Hospital Trust of Pordenone. That is one of the healthcare authorities in Friuli Venezia Giulia. Beatrice, if you want, you can start.
Thank you, Claudio. Good morning, and thank you for invitation this interesting event. I would like to tell you about FVG tackled COVID-19 from the point of view of data integration. So the COVID-19 emergency was an opportunity to rethink the role of technological innovations within our regional health system. It has imposed an acceleration of several areas for the management of a pandemic to the increase of new solutions and services capable of responding to emerging needs of patients. A year of intense work that led to the results highlighted below. The Friuli Venezia Giulia has a health information heritage with a significant temporary depth. We have a database that represents the integrated epidemiological system since 1979 and can be seen from the graph display. The colors differentiate the types of data from the territory to the hospital, to the social. So we can find different colors in different databases in which we can have a lot of data from the 1979. This is an example of the infrastructure that is very complex. It contains 50 data warehouse and plus 200 data marts. And we have 300 ATL, extract, load, transformation, and load of first level, and 200 data mart of second level. And the result are data mart able to produce data analysis through reporting and business intelligence tools. The integrated system COVID-19. During the COVID period, the integrated COVID system was implemented with the collect all the data relating to the pandemic. Vaccination, swaps, hospitalization, and the all cross-section data, such as a single registry, employees of healthcare companies, guests of retirement home, and so on. In that slide, we can find the different database about vaccine administration, vaccine realization, centralized registry, laboratory test, healthcare personnel, hospitalized, and reporting and evaluation forms, all database with the ATL form the integrated data warehouse COVID-19. The data warehouse is built from which data is extracted to feed business intelligence system and for ministerial flows. Much of this information feeds we can find in the electronic health information exchange. It contains the clinical history of the patient, represented by the set of data and clinical documents produced over the period of his life. Only digitally signed documents are automatically uploaded from the regional IT system to the HIE. Access by health professionals to the HIE facilities, both treatment and emergency intervention. We can find a typical platform, digital platform of region Friuli Venezia Giulia about future sanity future. In Friuli Venezia Giulia, access to HIE can be done through SPID, Public Digital Identity Service, a type of access to the public administration, regional sanity cards, and electronic identity card. Each access to the file is tracked and made visible in the history of the file itself. The acceleration dictated by the events has led to an increase in health documents in the electronic health information exchange. For example, you can find personal data and exception certificate, first aid access, hospitalization, medical reports, patient summary, vaccination, and personal annotation. Health data is seen by both patients and health professionals. But during the pandemic, we can add a different feature in the HIE, like celiac disease budget, pediatric balance, book, cancel, or change an appointment, and prescribe. Other clinical documents have been employed in recent months, such as molecular and antigenic swabs, COVID hospital discharge letter, certificate of healing, first and second dose vaccination certificate. In this way, the patient can always have information relating to their state of health available. As you will hear from my colleague later, this information will feed the European Digital Green Certificate. As you can see, in the first 5 months of 2021, there was a significant increase in access to the HIE equal to 71%. Patients access the system to download clinical documents related to the COVID. Remember, swab result, vaccination, and recovery certificate, as well as all the other clinical information that we have seen in the previous slide. These are the examples of dashboards to monitor the phenomenon of access to the dossier by month, by day, by type of document, and by sex. It's also interesting to see the breakdown by age group of users who access the file. Below are some representation of directional dashboards that allow us to evaluate the progress of vaccination, the geographic distribution of a vaccinated person, and the type of population by the age group. There are just examples of a very complex dashboard that is fed by all the health databases that have been appropriately collected and standardized. Another dashboard detects all the information related to very important health surveillance in this period, and through geographic representation, the so-called infected cluster and are identified. In conclusion, much has been done, but we still have to work hard to cooperation HIE of the other Italian region, booking a specialist examination from e-prescribed, print regional health ID, and manage medical exemption certificate with the co-design with citizen users. We are on the right way, but we run data and not the citizens. So I leave my colleague, Engineer Maurizio Rizzetto, who will continue to tell you about the developments that the Friuli Venezia Giulia region has made to meet external requests to run data and not citizens. Thank you for your attention.
Thank you, Beatrice. Very interesting and impressive numbers. I believe that no one believed in the past that HIE system will be used for epidemic emergency like the COVID. I think that it's very nice to see how citizens improve their use in HIE system during this COVID outbreak. And probably we need, as you have said, we need to rethink some functionalities, some services that we will offer using HIE system. So very, very interesting. So Maurizio, I give the floor to you, and please. Maurizio, you are mute. Unmute your mic.
Okay, now you hear me, sorry, but do you hear me? It's okay?
Yeah, it's okay.
So sorry, good morning to everyone. I would like just to give you an idea on which is the architecture of the health information exchange we have in the region, Friuli Venezia Giulia. Remember that it's a national project where every region is going to expose through a registry all the reports and all the documents that are in our repositories. So as you can see, the basic on the architecture is based on the XDS for documents, MHD, and you can see that there is a and the so-called INI, which is an international sorry, it's sorry. It's a national infrastructure for interoperability. So as you can see, Italy is split in different regions. We are the most north region in the east part of Italy, and we collaborate at the national level, but every region has to expose through his registry, as I said before. So the health information exchange in our region, so-called Sesamo, through Sesamo, the fascicolo sanitario elettronico, which is the name we give in Italy to the health information exchange, is the way where the citizen can reach all the documents through this REST interface. So you can see that there is the paradigm of typical of XDS and document consumer, document producer, and all the transaction that you can see in this picture. So starting on having a point of view on this architecture, a question, especially during the lockdown phases, was how we can give the possibility to the patient to have reports, and not only reports, but also images from the radiology, for all the radiology departments of our region. And we thought that the right way was starting from the health information exchange of our region, because this gave us the possibility to use all the authentication system that the IHE, the Health Information Exchange has, because it's very strictly, and it responds on all the safety rules and also on GDPR. So we thought that the right way to give the possibility to the patient to discharge all the images was through this health information exchange of the region. And we started to work on that. And after a couple of months, we started to use a system in one of the provinces of our region, just to do some tests and to see if it works. And now it's working in all the region. Just from the last month started to be used, and the citizen or the patient can discharge the images in a ISO mode, so he can produce alone the media CD or the USB pen as he wants, where all the images are inside in DICOM, full DICOM, and it's the same as coming to the hospital to take the CD and the images before. And this avoids him to go to the hospital. This is for our region something new, and it is very interesting for our patient. So the withdrawal of the diagnostic images, as you can see, is now on place and can be used. Of course, we are trying to solve some small problems for the beginning phase, and we want to develop the system, because today it's not possible for the healthcare professionals to use the system. But since there is also in our region, since 7-8 years, a PACS project for all the region that is based on XDSI architecture, we are going to give in the next month the possibility to the doctors, to the physician, to access through the PACS system to all the images of the patient. So this is something that they ask a lot us, that they want very strongly, and we are going to give it in the next month. This is the simple interface that the patient, the citizen, is going through. So he's just authenticating to the system in a strong way. And afterwards, he has just to do a click and he receives some instruction on how to produce the CD with all the images. But Sesamo is not only doing that, as Beatrice said before. It's possible, this was another important result, that the patient can reach his prescriptions from the general practitioner and going to the pharmacy to receive the medicaments without going to the structures. And so he can do it also for family members and by different doctors. So the dematerialized recipes are presented in the system, and of course, as I said before, everything is compliant with a very strict authentication system. So the recipe is also can be used in different regions, because as I told you before, there is a national level, and we did together with Claudio some demos in the past to test the national level interoperability of the system, and it works. It's not completely functioning at the national level, but the system is in place and has, I hope, is going to be completely implemented in the future. And of course, the electronic health is going also to help us to send the vaccination flows, through the vaccination flows, all the information needed for the digital green certificate. And all the information about the healing of the patient that was undergone on COVID illness, molecular buffers, antigenic buffers, and so on. So the citizen is going to find there all the information, all the certification that he needs for his normal life. So online booking for vaccination is another important application we have now with a safe authentication through app. So you can do it from mobile systems or from PCs, and you have 24 hours, 7 days by 7, the possibility to book, to do cancellation without doing very queues, and to book your vaccination. And this is very appreciated from the patient. So that is everything we did in the last month, a lot to do, and a lot we have to do in the future. Thank you.
Thank you, Maurizio and Beatrice, for your excellent presentation. We have 2 questions in the chat. The first one is from Charles Parisot. How complex was the creation of the ETL process to aggregate cross databases? What about duplicate encounters, etc.?
So we have an inside company in our region that, as Beatrice said, that deals with all these databases since 30 years, more or less. So for us it was very important to have their collaboration. And on the technical point of view, I'm not in the condition to tell you exactly what was going on, but there was an intensive job with them in the last months. And if Charles wants to have more information, we can give him a contact with them and to go through all the details. Okay, but I'm not in the condition now to give him more information.
Okay, well, thanks.
Sorry.
I hope that answers your question, Charles, and reach out to Maurizio if you would like to have more details. The second question is from Diana Ovelgunne. Are you using fire on any part of the solution?
Yes, as said, there is a part, as you have seen in my slide, where we use the MHD mobile access to health documents. In that part, in the REST interface, we started to use a part of Fire. Yes, we are the beginning.
Okay. Are there any more questions? You can also unmute yourself if you like. We have a few minutes left.
Okay, it's okay.
Charles Parizeau, I would have another question on the XDS deployment you just discussed. Could you give us a little bit of a sense of the size of that deployment? How many entities are interconnected? How many documents? How many patients? A little bit of the sense of size of deployment. Thank you.
Charles, I'm going I don't have exactly this data now, but just to give you an idea, we have in our region 1.2 million of people, and we have more or less 20-25 radiology department, and we have laboratories, and all the laboratories in our hospitals are connected. All the radiology are connected, so everyone is connected. So if you take in account that we are 1.2 million of people, maybe you can have a rough idea on how much documents we produce every year, because all the laboratory in our region and all the radiology are inside the project. So
Okay,
these are the biggest producer of documents, and so since we are doing it since 8 years, more or less, you can have a rough idea on how many documents we have in the project inside, in our repositories.
Thank you.
Thank you. Maybe one last question. If not, then thanks again, Beatrice and Maurizio, for your fantastic presentation. Really impressive work you are doing. Then I'd like to switch over to the next speaker of this session, who is my colleague at Nictiz, Maayke Klinkenberg. And Maayke has got lots of experience as an information analyst. She has been working in several Dutch hospitals. And today she will share with you a story on a cross-border exchange of medical images between a German and a Dutch hospital. So Maayke, please, the floor is yours.
Thank you, Esther. Thank you. And well, before starting my own story, I just would like to tell Maurizio that it was very interesting to hear in your story about the role that the patients are playing in your region regarding the exchange of their images, that they have the opportunity to obtain their images and share them with the doctors. So really interesting. I'd like to hear more about that in the future. But in Netherlands, we have a different approach, at least in the project I'm going to tell you about. And well, I'm really very happy to have the opportunity today to share our experience in this project with you. So thank you very much for this opportunity. I want to start by asking you to imagine that you live in the center of the Netherlands, for instance, and imagine that you need specialist care. Well, depending on your health insurance, you can find doctors in an area all around your location. And you have a choice, you can choose, and based on the criteria that are important to yourself. But when you live in a border region, then the situation is different, because then your options are often more limited because, well, despite all the European agreements, the borders are still somehow present there. And at least they are when healthcare information has to cross the border. And the Border Region Project, which is an initiative of Nictiz and the Dutch Ministry of Health, Welfare and Sports, with the Border Region Project, we can help to remove these obstacles. And I am the project manager of this project, and I work for Nictiz as an advisor on international information exchange. And to tell you a little bit more, now I'm trying to go to the next slide. Yes, it works. To tell you a little bit more about Nictiz, we are the Dutch Competence Center for Electronic Exchange of Health and Care Information. We work on standards and information standards for health information exchange. We are also the National Release Center for SNOMED in the Netherlands, for instance. And as a knowledge center, an important part of our task is to collect and to share knowledge on the electronic information exchange. And not only in the Netherlands, but we also focus on international developments and cross-border aspects. And that is how we started the collaboration with healthcare institutions in the border regions. Now, in this session, I want to share with you the background and the methods that we applied in the Border Region Project, and especially in the first use case of the project, which involved the exchange of medical images between the Maastricht University Hospital and the University Hospital in Aachen, in Germany. We learned a few years ago that in the border regions of the Netherlands, healthcare providers on both sides of the border quite regularly collaborate, and they also often divide work for specific healthcare processes. Now, this way, they're able to provide the best possible healthcare at the shortest possible distance for the inhabitants of these regions on both sides of the border. It could be, for instance, that a German or a Belgian hospital has the knowledge and expertise for a specific high-skilled treatment, which is not available in the nearest Dutch hospital. And it could also be that a Dutch hospital is simply closest by for German residents in a rural area. Now, until now, there is hardly any electronic information exchange in these collaborations. Usually the information is exchanged on a CD or DVD, on a USB stick, via the mail, or even on paper. And the Border Region Project aims to change that. Now, first of all, what do we want to realize? Since a few years, the Netherlands are actively implementing the European policy for cross-border information exchange. We are preparing to participate in the eHealth DSI. So we will be able to receive patient summaries from other European member states, hopefully by the end of this year. But this is a long-term process. And about 2.5 years ago, the plan came up to expand our knowledge of cross-border exchanges and to gain more hands-on practical experiences, for instance, in the border regions. That is where the challenges exist. And both Nictiz and the ministry can contribute to these challenges by sharing our knowledge and expertise with the local experts. And we can learn from them, from their practical experience and the problems they have every day. And together we can work out the optimal solution. And an optimal solution is a solution that is not only applicable in this local situation, but it can also be applied elsewhere along the border. And that leads to an acceleration of electronic cross-border exchange, which is our ultimate goal. Now let's look at the first use case we took up, the use case Maastricht-Aachen. Now, since many years, the university hospitals of these cities are working together, amongst others on liver transplants. And you know that the Netherlands is really a small country. But for the inhabitants of the southern part, the area around Maastricht, the nearest Dutch hospital where liver transplants are performed is 200 kilometers away. And at the same time, in Aachen, which is only 40 kilometers away, this procedure is also performed. So that is why these hospitals collaborate. And each year, about 15 patients from the Netherlands can actually profit from this opportunity. Now, the specialists from both hospitals have a weekly joint consultation, which is mostly on location in Aachen. And there they discuss the patients, including also the possible candidates for this surgery. And in these consultations, they use an enormous lot of medical data, more than 80 different types of data. And as I said, until now, all this data is then recorded on CDs and taken by the doctors when they go to Aachen. And that is a cumbersome process, and it involves many steps, and it is also very risky. Data can be lost or CDs can be lost. It is possible that they cannot be read, they can fall in the wrong hands. Well, you all know what can go wrong there. And therefore, Maastricht was very keen on participating in the border region project to bring the information exchange to the next level. And that brings me to the next question. When is a use case actually eligible for the border region project? Now, first of all, the solution needs to be realized in a maximum of 1 year, because that is the maximum duration of a use case. And of course, that is a very ambitious time frame. And usually it is not the end destination or the end goal, but it is the first step on a longer journey. Secondly, we look at the nature of the information exchange, because our minister has recently selected 5 priority areas for digital information exchange in the Netherlands. And that is, amongst others, medication, for instance, medical images, emergency care, and also patient summary. Now, preferably, the use case for the border region project concerns one of these priority exchanges. And another option could be that the use case is one of the exchanges that are being developed in a European context. Think of lab results or discharge letters. And most importantly, the solution for the use case should not be a local solution, but it should be applicable elsewhere along the border as well. Now, the use case in Maastricht ticked all the boxes, because out of the entire data set, we first selected to exchange the radiological studies. That is only a small part of the large data set, but it is a nicely demarcated first step. And we thought it would be feasible to realize this in a year. Then the exchange of images is one of the national priority data exchanges, so it fitted in nicely with the national developments. And also, the exchange of images is one of the topics of the European project Cross eHealth. Cross eHealth defines the functional and technical specifications for cross-border exchange of medical images, lab results, and discharge letters. So this fitted in as well. And that meant that we could get started on the use case. So how did we do it? Well, the approach we follow is based on the European interoperability framework. Most of you probably know this model. It contains 6 layers that represent all aspects that should be addressed to achieve interoperability. And we feel that this is the only way that a truly working solution can be realized in a short time span, or indeed at all. And in every phase of the project, the interoperability framework is the backbone. And that means that representatives of each layer are also involved in each phase of the project. Now, as you can see here, there are 5 phases in the project. We start by defining the goal and scope of the use case, together with all the stakeholders involved, and we write them down in the declaration of intent. And that declaration is then signed by all the stakeholders to strengthen their commitment to the use case. The use case is coordinated by one of the major stakeholders involved. And an advisor from Nictiz is also from beginning till end involved in the project, but is not leading the project. That is done by a local project lead. And if necessary, Nictiz can bring in expertise from our colleagues or from the ministry into the project whenever it is needed. Now, after the scoping, the present situation is analyzed on each layer of the framework, and the present bottlenecks are identified. And after that, the desired situation, the solved situation, is described, and also the scenarios we can think of how to realize this desired situation. Following that, a decision must be made. Which scenario are we going to realize? What do we need to do to get that far? We make a gap analysis, an action plan. And after that, finally, the actual realization takes place. Now, in the case of Maastricht and Aachen, there were some favorable conditions because there is already a periodic consultation between the boards of both hospitals. And that enabled us to present plans on the right platform and to obtain their joint approval whenever it was necessary. And another advantage was the presence of a very active Chief Medical Information Officer, a CMIO, in the hospital in Maastricht. That is a role that is becoming more and more important in Dutch hospitals, and it is fulfilled by a medical doctor who is acting as a liaison between the medical specialists, the IT department, and the management. And by representing the end users with a powerful voice, and also by connecting all the stakeholders, these CMIOs, these Chief Medical Information Officers, play a big part in realizing the solutions that really work and that are really being used in the hospitals. Now, the thorough analysis that was made of the processes in Maastricht and Aachen and of the data that is very useful, not only for this project, but of course also for future developments. And besides all that, there was in Maastricht also special attention to the aspect of patient consent, especially in a cross-border situation. So this consent is now explicitly registered in the hospital system in Maastricht, and that procedure was checked with the ministry to see if it fulfilled, if it was complying to the regulations, which it was. Now, what did we do? Because when the experts were discussing the possible solutions in all these analyzing phases, it appeared that actually there was an easy way to realize the first step. Because in the Netherlands, the national twin platform is working on solutions for the national exchange of medical information. This is a broad collaboration platform where a lot of stakeholders are involved. Because you may know that in the Netherlands, we do not have a national health information structure or landscape. It is very scattered and decentralized. There are a few regions, but there are also individual institutions that are exchanging. And the twin program aims to create a connection between all these individual initiatives. Now, one of their projects was the project DVD Exit. And the goal of that project is to connect all hospitals to get rid of the use of DVDs for the exchange of medical images. Instead, so the solution that is used here is DICOM mail to exchange the images, because this is a low, how should I say, this is an easy to realize solution. And the goal of the DVD exit program project is also to realize a solution as soon as possible, to get rid of the DVDs as soon as possible. So this solution was being realized by connecting all the hospitals. And Maastricht was also implementing this solution. And when they were talking to the German colleagues in the Aachen hospital, they found out that there is a similar platform in Germany, the Westdeutsche Teleradiologieverbund. They didn't know that in the Netherlands. So that platform provides the same service to more than 500 connected healthcare institutions in Germany, and they were using also DICOM-mail. And that made it very easy to connect both platforms, which enabled the Maastricht and Aachen hospitals to exchange their radiology studies, including CT and MRI scans. Now, the connection of the address books of both platforms makes it technically also possible for all connected institutions in both countries to exchange images amongst themselves. So that is the scalability of this solution. Now, since mid-March, this solution is being used successfully in the weekly consultations in Aachen. And the staff is really happy with this solution. It is safe, it is simple to use, and it saves them a lot of time. And it's also, that makes us happy, a solution that can be used elsewhere. And that is why we want to share this experience and the lessons that we learned in this project. And if necessary, also the specifics of this use case. We will do that by sharing what we have learned in a fact sheet or a toolkit containing the practical details of the lessons that we learned, and also support for organizations that would like to follow the same approach for this kind of exchange in the border region. And what we also do is we share our story as much as possible in sessions like this one, or in articles and publications, to reach as many interested organizations as possible. In Maastricht, the lessons that we learned were more specifically that in the field of patient identification, there still is some work to be done, because as the patient group involved in this procedure was small, and in Germany, there is not really a patient number that is being used to identify patients. For this use case, patients are identified based on name, date of birth, sex, that sort of information. But for the next use case, we definitely would like to, well, to dive more deeply into this topic and find a solution which is really more generic. Also, we found out that it took quite some time to find the right experts in both organizations. And that is something we take with us for the next use cases, because it is really something you should start on very early in the beginning of the project, to find the right experts to take the right decisions and get a move in this project. Now, what's next? Well, fortunately, this success does not mean that the border region project is finished. No, we plan to continue with these kind of use cases. And at present, we are also working on a use case in the region of Enschede, which is a little bit more to the north. And that use case involves German ambulances bringing patients to a Dutch hospital. And we are investigating the possibility that the German hospital, the German ambulance will send a digital message containing patient information that can be received by the Dutch hospital, and especially by the emergency department, of course, in the hospital, because that way the emergency department can make sure that they are prepared for the patient and that the right team is ready to receive the patient when he arrives. Now, this use case is also developing very positively, and hopefully we can share the results with you in a few months' time. And besides that use case, we are also working on preparation for other use cases, also in the exchange with Belgium, because of course that is also a large part of our border. And in Maastricht, they also have plans to expand because they would like to use this solution also for the other collaborations between Maastricht and Aachen, and to expand this solution to the exchange of images in other departments. But also, they would like to expand the liver transplant exchange to other types of information, for instance, lab results. And further on the calendar in Maastricht is a migration to a future XDS solution that is being developed. So actually, I hope that our experiences can inspire you, and that it also shows that small steps really work. And so I would like to conclude my story by quoting the 3-step motto of our Maastricht doctor: begin by making it work, and then as a next step, make it better, and only then try to make it beautiful. Thank you very much.
Thank you, Maayke, for sharing this story. We do have some questions in the chat, so I'm gonna read it. They are both by Charles again. Do you believe, there's one more. Do you believe that it is better to deploy cross-border between 2 existing regional projects, each on one site, or to perform one at a national level between 2 countries?
Well, I think, of course, in the end, the solution would be to be able to deploy national exchange and national solutions. But the border region project is especially set up to accelerate actually this process and to create already in a small region working operating solutions that are in line with the national developments. So rather than waiting until we have both in the Netherlands and in Germany a working national solution, we start now already by deploying this local or regional solution.
Right.
So it is a step on a longer way. That is the way that we see it.
Yeah. Okay.
Yeah, it makes sense. That's a very good lesson. Thank you.
Thank you.
Thanks. And the second question by Charles: how dangerous is it to rely on the same vendor product to be used between the 2 regions across the border, not to be replaced, applicable to other regions that may rely on another vendor?
Yes, I understand your question. Well, I think for the Netherlands, we do not, we use the present, which is a temporary solution of the DVD exit platform, or the twin platform using DICOM Mail, which is nationally deployed. All Dutch hospitals are connected to it. So actually on the Dutch side, we use a national solution. And on the German side, it is indeed, I think, covering not the whole of Germany, but I'm not really aware of all the details on that side. But it is a platform that is connecting, as I said, more than 500 German healthcare institutions. So that is a question that we have received also earlier, is how is the situation in other German regions? Well, that is something that I think is interesting for us from Nictiz to have some research on, and to see how also in Germany this could be a scalable solution applied in other regions. But for us, it is the Dutch-German border, and that is largely North Rhine-Westphalia, and that is exactly where this German platform is operating. So the regions were large enough for us in this use case.
Okay, thanks. And then a remark or a comment by Evert Sanders. It is a point-to-point solution small amounts. Not sure what you mean, David, with the second part. No emergency doctor.
It's during daytime, so
Okay.
you can ask the secretary to organize it.
Yes, but as I understand, it is also possible. It is possible to use it 24/7. But in this,
I know, but
yeah.
well, we have those kinds of exchange also between my hospital in the south of Netherlands and a regional hospital, our neighbor for neurosurgery. Well, the exchange between the hospitals went well because the secretary people from both sides were used to use it, but in nighttime you have no service. So doctors were frustrated sometimes because during the nighttime they were not able to exchange. So it's for this use case, it's working.
For this use case, it is definitely working because this is, like you said, it is a planned process and a regular consultation that takes place each week, which is prepared by staff on both sides.
Yeah.
But I'm not really aware of the specific way it is implemented in Maastricht, because I understand that there are several varieties of implementation of DVD exit, involving, let's say, from mainly a manual operation to fully integration in a PACS system. So depending on the way it is implemented in a hospital, I can imagine that it might be more or involve more or less manual interaction. But I'm sure that you know more about that than I do.
Yeah, you can, but well, if the amounts become larger, you get in more trouble, and also the patient consent DVD is implicit. The consent of the patient, because it's, well, you exchange it now nearly manually, but if it becomes larger and you want to get images from other hospitals automatically, you have to organize the consent of the patient.
Of course.
And
yeah.
where is that consent? And well, that's more.
Yeah,
that makes it more complex.
That is a more generic consent. I agree with you. In this use case, the patient is providing explicit consent because, of course, also the operation takes place in Germany, and this is a special collaboration. So the consent of the patient is a special topic, and therefore separately registered by the doctors on this for this treatment. Yeah.
But people are glad with those kinds of solutions. So sometimes you must be satisfied with these simple, rather simple.
Well, that is the idea, to get some experience with these kinds of solutions, also on the longer run, to see does it work or what kind of new problems come up in that case. So,
I think that's a really nice point to end this interesting session. So again, big thank you to all the speakers, Maurizio, Beatrice and Maayke, and also to the audience and sending your questions for the speakers. So thanks everyone, and I hope you will enjoy any of the other sessions of the IHE experience. So hope to see you soon, and have a nice day. Thanks.
Thank you, Esther.
Thank you.
Thank you.
Thank you. Goodbye.
Thank you.
Thank you. Have a nice day.